Good morning, everyone. I'm Dr. Janvi Tandon, and I will be speaking on healthcare delivery system with the subtopic of healthcare challenges in India. The principal investigator is Professor Vidya-mitra with his colleagues in collaboration with his colleagues from Aligarh University. Before any topic is dealt with, it is important to know the learning objectives. And for the learning objectives to know what the healthcare challenges in India are, we must enlist the burden of disease in India, enumerate the challenges for healthcare in India, and we have to describe the healthcare structure for India. Now, I'm going to show you a few pictures, and this is one where the blood pressure instrument, where the blood pressure is being noted, and obviously it seems that there is a village group which is in attendance, and here the immunization services are on, and thirdly the weighing of under 5s is taking place, in which an Anganwadi worker, you can see, is weighing the child. And the fourth is, this is obviously a school in a rural area where the doctor has come, or the paramedical person must have come for checking up, for giving a medical checkup to these village school children. Now, the importance of these 4 pictures was to demonstrate that in all the 4 pictures, health services are being given at the village level, and the people are seen accepting these services very comfortably, very happily. If we can achieve the acceptance of healthcare at the village level with a comfortable mind and with a clean and an open mind, our work would be definitely become easier. Now, the top 7 healthcare challenges in 2014 for our country, with reference to our country, or for that matter any other country, there are 5 points on which we have. One is the lack of time for patient care. In today's hospitals or in the village settings, wherever OPDs are being conducted, we see that the number of patients do not match the time allocation of the doctor in the OPDs. The time is always less, the patients are always more. There is always a crowd, with the result that the doctor is hardly able to give maybe a minute to each patient. Now, in this 1 minute of patient-doctor relationship, the only thing which can be given is curative medicine. He asks the history, he gives the medicine, and that's it. The patient is gone and the second patient comes in. But here we see that there is no time at all for any preventive or promotive care which can be given by the doctor himself. The second one is the hiring and of trained staff. This is very important because you have to have, in order to give healthcare at the grassroots level, we need properly trained staff to see to the health services. And third one, we know that every new technology which is coming in is costing more. So this high cost of technology has to be seen, because if we want to give even the simplest technology help at the field level, we have to allocate money for the same. Then the patient influx, this matches the lack of time for patient care. It's always patient-doctor relationship ratio is always very awry, and we have a less number of doctors, we have a larger number of patients per doctor. Then increased emphasis on patient payment collection. And the 6th one is we have to follow the government mandate. The 7th one is the changes made by insurance payers. Now, as far as this insurance is given, or the patient payment collection is done, we have to know that this is mostly would be fitting in the urban areas, where we have the insurance schemes, and we have the insurance schemes covering the patients. Now, in the introduction, historically, the The Indian commitment to health development has always been guided by two principles with three consequences. The first principle being the responsibility of healthcare. The second principle after independence, free medical care for all and not merely for those who are unable to pay. This is very important because our country had decided that we need to give free medical care and it must reach the complete to the grassroots level. And responsibility of healthcare becomes a government responsibility. Therefore, in order to give healthcare, we have to make programs wherein there would be a free flow of healthcare through trained staff right from the top to the grassroots level. As a result, the first set of consequences would be inadequate priority to public health. This has always been the talk that whenever health comes in as regards improving the economy or improving the building structure or building roads, public health or health per se falls short of importance. Now, and there is always a poor investment in safe water and sanitation. Schemes were started by the government in order to build water hand pumps in every village, because it was said that every village should have its own water source and hand pumps. The question was, the hand pumps were put in, but it was not seen whether these hand pumps were in working order or not. And still in areas like Rajasthan, where the women still walk for miles early morning in order to fetch water for their families. Sanitation was never a topic of interest for our public health and health sectors, and thereby neglect of the key roles of personal hygiene in good health, culminating in persistence of diseases like cholera and many other communicable diseases. The second set of consequences to substantially unrealized goals of national health policies in 1983 due to funding difficulties from compression of public expenditure and from organizational inadequacies. Third set of consequences, inability to develop and integrate the plural systems of medicine and the failure to assign practical roles to the private sector and to assign public duties for private professionals. This was important because we know that allopathic medicine is being given. Now, in order to make the use of traditional medicine, which has actually been handed down in families for generations, and people have faith in it. So, therefore, what the government is now trying to do is trying to integrate the Ayush, that is the five traditional medicines of Ayurveda, Unani, Siddhi, homeopathy, into this present allopathic system, so that healthcare would be more acceptable by the peoples at the grassroots level. And this is clear from the fact that compared to the richest quintile, the poorest had, in fact, it has always been seen in our countries that despite the fact that money is being put in for healthcare, training of staff is being given, but still there remains inadequacy, and therefore the infant mortality rate and the child mortality rate was still 2.5 times more. The total fertility rate was still double the rates, and with the result that 75% of malnutrition, particularly during the 90s, has been found to be highly prevalent. Large differences also exist between districts within the same better performing state urban areas, and they appear to have better health outcomes than the rural areas. So there is always again a difference between the urban presentation and the utilization of health services and the rural areas. And we have said time and again that for those for whom the health is required, that is for the poorer sections of the society and for the better outreach in the rural areas, but it is always seen that it is all the health outcomes as well as health utilization is always better in the urban areas. Although the figures may not fully reflect the situation in urban and peri-urban slums, with large in-migration. Now, in the urban areas and in the peri-urban slums, there is another problem of migration. Despite the fact that whatever money might be put into health sector or into other developmental sectors for public health, there is always a migration, which is ongoing process of migration from the rural areas into the slums and into the urban areas, with the result of overcrowding and increase of communicable diseases within this because of the overcrowding conditions. India is, of course, a vast and complex country, and despite economic development, its healthcare system is absolutely inadequate to deal with the country's main health challenges, that is, infectious disease, chronic diseases, and poor maternal and child health. Because these are the areas wherein it is difficult to convince people to use these services as it is necessary to them. India is passing through a demographic and environmental transition, which is actually adding to the burden of disease. What does this mean? The demographic and the environmental transition which we are passing is the building of new buildings, construction of more urbanization coming in, more of roads being created, with the result, the shift from the rural to the urban slums, and with the newer jobs coming in, and with the fast track effects, the use of the newer cultural things, that is, eating habits change, lifestyle change, and as such, the new burden of diseases would consist of cardiovascular diseases, road accidents, obesity, and of course increase in diabetes, and because of closeness and newer ideas which are coming in, sexual promiscuity has come in. So therefore the sexually transmitted diseases are also on the rise. And let us not forget HIV, the spectre which is always in the background. The first half of the 20th century witnessed a large number of communicable disease epidemics. And there have been major improvements in public health, of course, since 1950s. Now, affordable medicines and tools are available. Like we said, that technology is improving, and with technology, we are using newer technologies. We are using affordable medicines and these tools which are now available and which are highly effective when used very appropriately. And examples of this is the anti-tubercular medicines, anti-malarials, insecticide-treated bed nets, and condoms to prevent HIV and sexually transmitted diseases. Now, anti-tubercular medicines, because through the National Tuberculosis Program and through the National Malaria Eradication Programs, insecticide-treated bed nets were given, but how far they were used and how comfortable they would have been was not evaluated. And as a result, tuberculosis, malaria, and the other filaria and other communicable diseases, although decreasing slowly, are still very much present in our communities. However, there have also been health consequences of urbanization and industrialization. There is persisting inequality in health status due to varying economic and social political causes. Now, developing countries like India face a triple burden of diseases from the unfinished agenda of communicable diseases, emerging non-communicable diseases related to lifestyles, and emerging infectious diseases. Like I have already described, that we have still not been able to control fully the communicable diseases, gastroenteritis, diarrhea, malaria, filaria, and other diseases are still tuberculosis, malaria. We are still seeing these diseases, and the other diseases communicable which are prevalent and localized to different parts of the country. And with this, we have now started the additional burden of emerging non-communicable diseases which are now related to lifestyle, and the emerging infectious diseases which are now coming in. So for all this, we have to have healthcare management. For healthcare management, unless you have a cyclical motion in continuum of 5 factors such as clinical data management, healthcare policy, economy of healthcare, quality assurance, and timely healthcare delivery, it is not possible that because all these factors are absolutely closely related to healthcare management, and therefore each one has to be seen in its not only in its single position but in the entirety of the continuum of care. Healthcare indicators actually still continue to lag. Outcome indicators such as infant mortality rate and life expectancy continue to fall behind the other averages. And this is because that we have still not been able to deliver the services and increase the coverage of the services to 100%. Because there are still women in the rural areas, there are still women in the slum areas who refuse to come for an antenatal checkup, with the result that either there is premature delivery or there are delivery complications even apart from this, even the post-delivery care of the infant is not very good, resulting in high IMRs, and life expectancy still continues to fall. It is likely that India will fall short of the 2015 targets for infant mortality rate and maternal mortality rate set for the Millennium Development Goals. Now, non-communicable diseases have surpassed communicable diseases as the most common causes of morbidity and premature mortality in the country. Healthcare spending, and it is important to know that we have from time and again, we have said that because health is a secondary subject, not as important as those in others. For example, we want to improve electronics, we want to improve lifestyles, we want to improve fast foods, but nobody is bothered about putting in adequate amount of expenditure for healthcare. As a result, India's healthcare spending as a percentage of GDP has in fact reduced from 4.4% to 4% over this past decade of 2000 to 2010. And unfortunately, because healthcare is not given evenly and it is not accessible to everyone, out-of-pocket spending still continues. Because there's one particular reason. If medicines are not given in full, if technology is not given in full, that person he gets only half of the healthcare which he should be getting, and for the other half, he has to give an out-of-pocket spending. Infrastructure gaps remain substantial and are exacerbated by undernutrition of existing resources. Total bed density has increased from 1.3 per thousand by 2010, but remains significantly lower than the WHO guideline of 3.5 beds per thousand. Now, this we can see that total bed density may have increased, but because there has been an uneven rise in the population, so that gap still remains. And as a result, today we can see overcrowded hospitals overflowing with patients who are actually using the space on the ground in order to be admitted or for a waiting period till they can get a bed. Underutilization of existing resources further compounds the problem of meager infrastructure. Private sector hospitals routinely face utilization issues. Public sector facilities remain low because of ignorance, because of non-communicability of the workers to the public to tell them of the importance of these facilities which are meant for them and which they will not utilize unless they have complete faith in them. The health workforce remains inadequate and underutilized. The total number of allopathic doctors, now we need doctors, and yet the country is lagging in the WHO benchmark of 2.5 doctors per thousand population at 2.2 per thousand. And with a high proportion of the Ayush doctors and rural medical practitioners who are not actively involved in this formal sector, the density still falls further to only 1.9 per thousand. So, in spite of the fact that we have a particular set of trained doctors who may be trained in the traditional medicine, we are not being able to utilize what we have in hand so that a larger amount of public can be reached. Public-private collaboration has not achieved scale. Somehow, this triple P, the public-private partnerships have not been very successful, although some programs have been successful, but none of them have been scaled to meet India's health challenges. While government-sponsored social programs have grown rapidly, nearly 75% of the population remain uncovered under e-healthcare structure of India. This picture shows the uneven contribution of the health services per se of India, per se the other countries. And we find that, for example, countries like India and Russia are still going in the minus, and as far as health expenditure, total health expenditure is concerned, whereas the other countries have crossed over to the positive side. With the result that our figures of infant mortality, our figures of maternal mortality are still, though they may have come down, but they have not come down to that standard where it would make a mark on the figures of the nation. And we see that India still has a total life span has increased only to 69, whereas the other countries have gone up to 75, more than 75, 80. This is a detailed diagrammatic. Before we talk of, when we are talking of health, national rural health challenges, we need to know that what is the setup right from the center to the grassroots level. At the national level, we have the Ministry of Health and Family Welfare, Institutes of Health are there. The state and union territories, we have the Departments of Health and Family Welfare, we have the apex hospitals. In the districts, we have the district hospitals, and in the rural areas, we have the community health centers, the primary health centers, sub-centers, village health guides, ASHA, and the trained guide. Now, the community health center serves for a population of nearly 1.5 lakhs, the primary health center for 30,000, sub-centers for nearly 5,000 each, village health guides 1 per 1,000, ASHA 1 per 1,000, trained guides 1 per 1,000. So you have these now. This is where this is important to know, because when we talk of primary health care and we talk of extension of primary health care to the villages, this is the first level contact between the health sector and between the public, which is at the grassroots level. This is important because this is where, if this contact is strengthened, it would form a pathway for better health services and for better acceptance of health services. In the urban areas, we have the hospitals and the urban primary health centers and the urban health posts. To summarize, the healthcare challenges of India is actually manifold, and the prominent being, India lacks in the key healthcare indicators. There is a growing burden of diseases, inadequate and poor health planning is there, inequitable distribution of resources between the states as well as the urban-rural setting is there. And this is all because of the fact that we have not been able to, in spite of putting in money for the health sector, we have not been able, and putting in trained workers, somehow the coverage is where we are lacking. We are not able to give 100% coverage to the entire field areas, with the result that there is a shortfall in physical infrastructure, shortfall in trained manpower, minuscule health budget by the government. As the program is growing and as other important technologies are taking over, the health budget is being cut down because we feel that the coverage has been achieved, although the indicators still indicate that this is not the position. And more important, the high cost of advanced treatments have come in, so healthcare still becomes not non-affordable for our patients, for our larger sector of the patients from the rural areas. Then low insurance provisions. Insurance provision is only for the urban areas mostly, and as far as the rural areas are concerned, actually there is no insurance provision. And we have a very unregulated private sector which is growing only to improve its own technologies, to improve the distribution of technologies for its own paying population. The unresolved challenges of India's healthcare sector during the past decade hold at least 5 lessons for the future. First of all, an encompassing vision of future demand for health services should guide the vision and the roadmap for the Indian health system. And second, the prevention and early stage management should be a core focus area. This is particularly relevant given the rising burden of non-communicable diseases, because now we have to fight two sets: the communicable diseases which are still prevailing and the rising non-communicable diseases which are now coming in. Such investments can actually significantly mitigate disease and cost burden. Third, a constructive and transparent dialogue will be needed between private and public sectors at its early stage of journey. Fourth, the focus needs to be on efficiency, especially through better utilization. Finally, the large-scale implementation needs strengthening to see that the outreach is nearly to the tune of 100%. And in their attempt to reform healthcare, countries actually tend to undergo transformation in two phases. First, when political leadership makes a strong commitment to providing access to all citizens. Secondly, when having achieved access to a level greater than 80%, governments attempt to strike a balance between the cost effectiveness and quality of healthcare. And that is where this is dangerous, because when the money starts getting cut, the cost effectiveness is not going to matter that much. Delivery of quality healthcare services is considered a basic need irrespective of age, gender, culture. Indian healthcare system faces substantial challenges in providing quality healthcare. And to summarize, the healthcare challenge, this is a summary of the entire factors, and the most important factors that we are lagging in key healthcare indicators: growing burden of diseases, inadequate and poor healthcare planning, inequitable distribution of resources between states as well as urban-rural health setting, shortfall in physical infrastructure, shortfall in trained manpower, a small health budget by the government, high cost of advanced treatments, low insurance provisions, unregulated private sectors that can be tackled through proper vision, focus on early diagnosis and treatment, strengthening of public and regulation of private health systems, ensuring effective utilization. And with this, I would like to thank you people for visiting the Pathshala. Thank you.